Everyone, now we will see how we are going to approach the jaundice. First is based on the history. So, what all the ideas we can get from the history? One is onset. So, within days if a jaundice is evolved, then it can be possibly because of infections or toxins. If it is evolved over a few weeks, probably it is because of biliary pathology. And some of the jaundice can be intermittent or fluctuating, and the causes could vary, like it can be gallstone induced or it can be because of any malignancy of ampulla. So, such things. This is the primary symptom. Based on the associated symptom, we can get some idea. Like if pain is there, especially in the right upper quadrant, probably it is because of liver or gallbladder inflammation. We also have got Murphy sign, where there will be a catching type of pain in the right upper quadrant. There can be epigastric pain. Epigastric deep-seated pain is usually seen in pancreatic pathology. Dark urine, pale stools, pruritus. Both of them are indicative of obstructive jaundice because bile acid deposition in the skin and the elastic tissue can cause pruritus. And dark urine is because of presence of direct bilirubin in the urine as well as bile salts and bile pigments. Pale stools is because absence urobilinogen and stercobilinogen in the stool. It causes pale stools. Fever, it indicates probability of infections or inflammation role in the jaundice. And nausea, vomiting, weight loss. All these are constitutive symptoms which can be also seen in malignancy as well. Past history, so previous history of blood transfusions, because unscreened blood transfusions happened before 1990s, and they are implicated in transmission of hepatitis B viruses, hepatitis C, and all these are implicated in viral hepatitis. Abdominal surgery could have caused post-op strictures. Previous history of malignancies, metastasis could have caused obstructive jaundice or hepatocellular jaundice. Hemolysis in the prehepatic jaundice. And inflammatory bowel disease. Past history of inflammatory bowel disease indicates probability of primary sclerosing cholangitis, especially seen in male population. And personal history that assesses the risk-taking behavior of the person, which are implied in some of the liver pathology. Drug and treatment history. In the latency period of around past 180 days, if the person has consumed some kind of drugs, it could be even hydrogenic or normal about evidence-based medicines or native medicines or supplements. Family history, which indicates some kind of congenital role in the liver pathology. Next, coming into the physical examination, we have to look for signs of liver failure, jaundice, needle marks, tattoos, or piercings, bleeding manifestation like subconjunctival hemorrhage, spider angiomata, palmar erythema, muscle wastings, gynecomastia, testicular atrophy, pedal edema, ascites, theta hepaticus, and flapping tremors, etc. Coming to the systemic examination, GIT system, there can be ascites, engorged veins, cirrhotic kind of liver can be there if there is liver cirrhosis involved, and spleen can be enlarged. There could be even nodularity in the liver. And examining the other palpable organs, there could be palpable gallbladder. And according to Courvoisier law, if there is palpable painless gallbladder, it is probably because of malignancy and not because of stones. And other related systems. So based on the liver pathology, if there is any kind of liver failure, on examining the CNS, there can be impaired consciousness, flapping tremor, etc. Associated tachypnea can be there. And in obstructive jaundice, there could be sinus nodal deposition of the biliary salts and pigments, and there could be bradycardia. To the lab parameters on routine examination of complete blood count, there could be anemia, thrombocytopenia, anemia because of hemolysis, and pancytopenic picture because of splenomegaly induced also. ESR and CRP can be elevated if there is some kind of inflammation, infection, or autoimmune etiology involved. Renal function, if there is hemolysis or hemorrhage involved, usually there could be elevated urea creatinine ratio, or impaired renal function. Coming to liver function test, the total bilirubin in jaundice is going to be elevated more than 2, and indirect bilirubin will be elevated in prehepatic. direct bilirubin in post-hepatic, and there could be mixed bilirubinemia in hepatic kind of jaundice. Alkaline phosphatase and gamma glutamyl transferases will be elevated in case of obstructive jaundice. AST-ALT elevated in hepatocellular jaundice. AST-ALT ratio, if it is more than 2:1, probable etiology is alcohol. And if it is ALT is raised, probably because of non-alcoholic or viral. Other tests indicating liver functions are serum albumin, prothrombin and INR. So serum albumin could be reduced, PT prolonged, INR can be elevated if there is failure. Next, we will be doing imaging since liver is involved, ultrasonogram of the abdomen, CT abdomen. If this is not picking up the problem, then we will go for MRI or MRCP, magnetic resonance cholangiopancreatography. Suppose if there is a pathology or if we have to investigate or treat, we can use ERCP. We can retrieve the stones too. Endoscopic retrograde cholangiopancreatography and chest X-ray. And normally bilirubin is absent in the urine. Okay. So in the urine, bilirubin will be normally absent. What is the significance is in obstructive jaundice, uh, the bilirubin will be present, and the one which is present will be only conjugated. Okay. And urobilinogen will be absent because there is the conjugated bilirubin is not reaching the intestine. So the stools will be pale in color. We will talk about some of the special tests which are ordered based on the suspected pathology. So if infective etiology is suspected, a viral panel for screening the hepatitis virus A, B, C, E can be ordered, HIV too. And if bacterial, for bacterial leptospirosis, ELISA can be ordered, and blood and urine culture sensitivity can be done. Suspecting autoimmune etiology, you can do a ANA, anti-smooth muscle antibodies, anti-LKM1 antibodies for autoimmune hepatitis, anti-mitochondrial antibodies for primary biliary sclerosis, and serum IgG4 for IgG4 cholangiopathy. Suppose you're suspecting some kind of hereditary pathology, you could order serum ceruloplasmin 24-hour urinary copper if you're suspecting Wilson. And in case of hemochromatosis, you could order serum iron studies and transferrin saturation level. Alpha 1 antitrypsin in case of alpha 1 antitrypsin deficiency. This is the algorithm. If there is isolated hyperbilirubinemia alone, okay. If there is isolated direct hyperbilirubinemia, you could suspect Dubin-Johnson's or Rota, or indirect hyperbilirubinemia. It could be hemolysis, drugs, Gilbert's, Crigler-Najjar, or neonatal jaundice. But there is no isolated hyperbilirubinemia. Associated with hyperbilirubinemia, there is also impaired liver parameters. So it could be either hepatocellular or obstructive. So we will look into the liver enzymes. If the AST-ALT is more than the alkaline phosphatase, if it is elevated more than the alkaline phosphatase, probably hepatocellular. Whereas if alkaline phosphatase and gamma glutamyl transferase is elevated more than the AST-ALT, probably it is because of cholestatic pattern. Thank you. That's all for today's session.